Noreen Womack. I'm a pediatrician, mainly working out of Caldwell with the school mobile clinics. So, actually, really excited to share about rashes and skin conditions today. I actually love diagnosing rashes. I get texts of pictures from friends and family all the time. So, happy to share some of this with you. Next slide. So I have a few objectives today. I want us to have a common language when we're talking about rashes. And first and foremost, I want you all to be able to triage rashes, to know when a rash is an actual emergency, and those conditions will be marked in red. When a rash just requires a visit to a medical provider within 12 to 24 hours versus just maybe warrants a call to the parent or guardian. We're going to go over a bunch of different skin conditions, and I'm going to have you guys help me. We'll talk about that in a little bit. And then the last slide is just the most recent in wound care that I noticed that isn't universally known. So want to go over that at the end. I'm going to run through my slides. I want to be able to get through all my presentation, but if you have questions, please put them in the chat, and hopefully I'll leave enough time at the end to go over those. Next slide. So as they say, a picture is worth 1,000 words, but if you don't have a picture, we have to have a common language to talk about rashes. And so I'm hoping that this is a review for a lot of you. So I'm going to run through these pretty quickly because we're going to see these terms coming up over and over again in the next hour. So to start with, morphology. So a macule means, or a macular rash is a flat rash. A papule is a bump. A vesicle is a bump, but this time it has usually clear fluid in it, and the wall around the fluid is thin. A pustule is the same thing. It's fluid filled, but typically it's more cloudy fluid. The wall might be a little thicker. A nodule is a big papule. We use that often to describe larger warts, for instance. Maculopapular is a very common term because many rashes have both flat and raised components. And then follicular is pertaining to the hair follicles in the skin. So a follicular rash will have that goosebump appearance. Most rashes are ovoid or circular in shape. There are exceptions to that. One of them is dermatographia. That is a skin condition when there is so much histamine on board because of allergies that any trauma to the skin will cause a rash in that traumatized area. And so if you have this condition and you scratch, then you're going to have hives in the shape of where you scratched as an example of a different shape. Another thing we'll talk about later is how important the difference between a rash that is well circumscribed versus diffuse. Also, another very important characteristic is if the rash blanches or not. So that means if you press your hand against the rash, does it blanch? Does it go away and then slowly come back? And if that happens, then you know that you're dealing with a rash due to vasodilation. So that means that the redness you're seeing are the red cells that are in each individual blood vessel in the skin, but can go away if you press on it. Versus a non-blanching rash, where that's where the blood is actually extravasated into the skin itself, bled into the skin. So an example of that would be like a bruise, which obviously doesn't blanch. Color can obviously vary. It's good to describe the affected area and then how a rash spreads. If it does spread, does it start out in one spot and then spread outwards centripetally? Does it start on the head and go down distally? All of those are clues as to what is causing the rash. And then finally, if there's any pruritus or itching or pain. Next slide. So these are the rashes that require urgent evaluation. So first of all, any patient who is ill appearing, it doesn't matter whether they have a rash or not. You should start with your ABCs. and that's your airway, breathing, and circulation. In your case, that's doing a quick assessment of the patient, checking vital signs, and certainly if there's any vital sign instability, tachycardia, low blood pressure, then you might be dealing with something that requires a phone call, again, whether the rash seems important to you or not. Another important type of rash is when the pain associated with the rash seems out of proportion to your findings. Thankfully, group A strep cellulitis isn't as common anymore, but some of you may remember the terms flesh-eating strep or flesh-eating bacteria. That was this particular type of strep cellulitis, and it often caused a very minimal rash, but since it was a deep infection, usually the pain was quite significant. The reason we don't see this as often anymore is because this was often associated with a bad varicella or chickenpox infection. So if somebody had a lot of chickenpox and got this infection, that this was a true emergency because the infection spreads quickly, goes deep into tissues, often requires debridement and surgery. Thankfully, that is not seen very often anymore, but still something to keep in the back of your mind. And then another red flag would be a rash that's associated with any kind of mucous membrane changes. So your mucous membranes are your conjunctiva of your eye, inside of your mouth, and actually in the anal area as well. And certainly there are rashes that can give you mucous membrane changes that aren't an emergency. For instance, adenovirus is a very common childhood virus that causes conjunctivitis, that sort of thing. Obviously, hand, foot, mouth is another common virus that isn't an emergency and can cause mucous membrane changes. But if you're not sure, it's just something to think about. And then finally, any rash that's suspicious of non-accidental trauma. So those are bruises that aren't over bony surfaces, old scars that might be consistent with objects, like a cigarette burn, or the outline of something that could be like a stick or a paddle. Those obviously require urgent evaluation. Next slide. So this is our first patient case. Once I go through this case, if you guys have an idea what this might be, please put it in the chat. And let's see what people think. So this is an elementary student that presents to your office that looks ill, has a high fever of 102. You also note that they have cold symptoms, cough, runny nose, and they do have red eyes as well. Since you're a fantastic nurse, you look in the mucous membranes and you notice white spots in the mouth that have an erythematous base. And you also note a 1 to 2 millimeter macular rash, some papules that blanch over the trunk, though the child said that the day before they were only on their face. And I actually saw already, yes. So next slide, please. So this is measles, and I put measles in red because this is one that you want to notify the family right away to seek care. There is an entire presentation on measles from the beginning of the school year. And so if you want to learn more, you can refer to that one. But for this talk, we'll just talk about the incidents and just a few key things. So far this year, there are over 1,200 cases of measles. And so we are well on our way to having way more cases than we had last year. Thankfully, we have not had any deaths yet this year, though we did have some last year. And then here are the statistics on this year so far in terms of cases. 77% in children, 89% were in unvaccinated or unknown vaccination status. 5% of cases required hospitalization. You can see from the CDC heat map on the right where most of the cases are. We are certainly going to lose our elimination status that we acquired in 2000 because of these cases. And so when this is a hot topic, as you all know, when you're speaking with your friends and family, Please remind them as health professionals that there is no cure for measles, that the vaccine is highly effective and safe. For the very young, this can be a devastating disease because of the complications of pneumonia and meningitis. But kudos to you guys who got this right away. Those are complex spots in the buccal mucosa. And so if you see that combination of cough, coryza, conjunctivitis, high fever, typically ill-appearing child, um, uh, rash, then you have to think measles. Next slide. So this case is a fourth grader passed out in the hallway, which is why they're brought to you. When you call home to let the mom know what happened, she says that he developed a low-grade fever, headache, and rash the day before. She says the rash started under his arms and on his wrists, but you notice it on his face. Temperature is 103. He does not look well. When you look at the rash more closely, you notice that it does not blanch when you press on it. And the way you would describe it are red and purple macules of different sizes, again, distributed throughout the trunk and the extremities. Does anybody want to take a guess on this one? So this is meningococcemia, and the clue here is that the macules are not blanching. And this is one of the true emergencies that you might see in your career. When you see a rash like this that is petechial or purpural, so that means they're not blanching. Petechiae just means they're smaller, 1 to 2 millimeters. Purpura are larger, like the middle picture. That is you want to call 911 even before you call parents, especially if they're ill-appearing and hypotensive, because time is of the essence. You can go from our patient's presentation to the right-hand picture within hours if you don't get appropriate treatment. In my 26 years of practice, I've had one meningococcemia case. It was a toddler who had presented to the ER the night before for fever. I was just seeing them in follow-up. The fever had gone away. The ER had done this whole workup that was negative. The only clue was the child had petechiae on his trunk and ended up in the PICU, the pediatric ICU. Eventually did just fine, but it is one of the scarier diseases out there. And just incidentally is one of the 6 vaccines that has been eliminated in the CDC vaccine schedule. Next slide. Next case. So junior high student comes to your office because of sudden onset of coughing fits. She seems to be slightly out of it, not really answering your questions, says she feels a little dizzy. You don't know her super well, but she might have some facial swelling. And she says that when she coughs, she feels like she's going to throw up. When you look for a rash, she's got a little bit of one on one cheek, some splotchy, pinked, raised areas. But mainly what you notice about her skin is that she appears pale. Anybody want to venture a guess? Oh, good job, Maureen. So this is anaphylaxis. And the definition of anaphylaxis has changed over the years. Several years ago, this is what they have come up with so far in terms of criteria. So our patient fit criteria 1. She had acute onset, minutes to hours of skin and mucosal symptoms and respiratory compromise, reduced blood pressure. If you took her blood pressure, I should have mentioned that. That might have helped you guys. She was pale, so you took her blood pressure and it was low, or severe GI symptoms. That is enough to consider anaphylaxis. Criterion 2 is easier because it's a patient with a known allergen and acute onset of low blood pressure, difficulty breathing, even without any skin symptoms. In that case, also you would give epinephrine. So the take-home message here is to consider anaphylaxis and consider giving epinephrine because truly no one will fault you if you give epinephrine and it wasn't necessary. I attended a another presentation by an allergist who talked about a recent study that showed that really there are no long-term sequelae of receiving epinephrine because there is a lot of concern about epinephrine because of its side effects. But it turns out that children, even more than adults, children and teens handle doses of epinephrine beautifully without any problem, even if they get multiple doses, even if they get overdosed, um, even if they have an underlying heart condition, really there are no long-term sequelae from that study. But we all know that the opposite is not true. If you require epinephrine and you don't receive it timely, that is a problem. So that's the take home from this. Next slide. So urticaria, um, I'm sure have seen this a lot because it is very common. And it can be very scary when you are watching a child like in front of your eyes have big blotches on the face and then they go away and then all of a sudden they've got this ginormous splotch on their leg. But honestly, urticaria in the absence of any facial swelling or breathing issues is pretty common and often benign. So when you see hives, you want to check those things. You want to make sure the vital signs are stable, that there's no facial swelling or neck swelling or difficulty breathing of any kind, even if it's just like a little bit of a cough. But if you don't have any of those things, then it really is a benign condition that only requires over-the-counter intervention like oral antihistamine. Um, Urticaria are very interesting because it's one of the very few evanescent rashes, meaning it can pop up somewhere on the body and then it'll go away on that part, and all of a sudden, 12 hours later, it'll pop up somewhere else in a very totally random other part of the body. But that doesn't, if that happens more rapidly or not, it means really nothing in terms of how long it's going to last or if it's more serious than another case. Um, it often actually turns chronic, where children and adults have chronic urticaria that can last weeks to months. Sometimes they never figure out why, but overall is benign. Next slide. So erythema multiforme, kind of staying with the whole allergy theme, is a type of allergic reaction. This rash is very dramatic because so these are circular papular lesions with central clearing, and typically the central clearing is got some purplish hue to it, so that it's very dramatic, very scary looking. Often, as it progresses, the lesions become confluent, and it is often due to some sort of allergic reaction. It is thought to be a version of hives, so it isn't quite as evanescent as hives. And when these children present to the ER, they get this huge workup, again, because of the dramatic presentation. But to be quite honest, as long as there's no mucosal membrane involvement, this is a pretty benign disease or condition, I should say. The rash can sometimes be uncomfortable and itchy and sometimes painful, uh, but there is no urgency as long as the child is well. And again, there's no mucous membrane involvement. When there is mucous membrane involvement, eye, inside the mouth, anal, that actually changes this to an entirely different condition called Stevens-Johnson's syndrome, which is something that requires urgent attention. But again, as long as those mucosal membranes are clear, usually this will go away by itself. It's self-limited. Next slide. So we've all seen cellulitis. When I was in medical school, we learned that in order to have cellulitis, you have to have four things. So tumor this is all Latin. So tumor means swelling, rubor means redness, calor is heat, and dolor is pain. And on the right hand side, that picture shows some lymphatic streaking. That's typically seen with a strep infection, strep cellulitis. On the bottom, you can see from the Sharpie marker that it started out as a large bump, and it's like spreading out centripetally or getting larger locally. And that is more typical of staph. We treat with the same antibiotics, so unless they require hospitalization, we don't need to culture. But yeah, that's just the basics of cellulitis. And I'm showing you this because, next slide, um, this is not cellulitis. This is one of my little pet peeves. So this is a bee sting or Hymenoptera. So that's bee, wasp, hornet, any of those sorts of stings. And many people have a delayed hypersensitivity reaction to stings. So not anaphylaxis, just a localized hypersensitivity reaction that actually takes anywhere from 24 to 72 hours to happen. And during that time, it can get bigger, and the area of swelling can get larger and larger and be pretty significant. But and it looks all the world like cellulitis, but it doesn't have all those four components because, yes, as you can tell from this picture, there's two more. There's rubor, um, there's calor, because if you put your hand on it, it'll be a little bit warm. But these patients typically don't have any dolor. They don't have any pain. If anything, it's a little bit itchy. And I'm telling you that most active in cellulitis infections do not itch. They hurt. And so that's a one good distinguishing feature. The other thing is bee stings or Hymenoptera stings very rarely get infected. And so when you see a reaction like this, you usually do not need antibiotics, though they often get them when they present like this to the ER. Next slide. So this is our next patient case. This student comes to you with a sore throat. You take their temperature and they have a fever of 101. They also, when you're looking in the back of the throat and you do notice it's a bit red with enlarged tonsils, they also say their tongue hurts. And when they stick it out, it looks like that. It's got that strawberry appearance. And you notice on their chest, they've got this sandpapery rough rash. It's like a papular rash. And yeah, next slide. This is a classic case of strep throat. So strep throat is the same thing as strep pharyngitis. Very good, Deborah. um, when there is a rash associated with strep throat, we call it scarlet fever. Scarlet fever is an old term that they used to use back when we didn't even have antibiotics. This is before penicillin. And scarlet fever used to be a very scary term to parents because before antibiotics, children would die of strep, and it was highly contagious. And so when I mentioned to parents, oh yeah, they also have scarlet fever with their strep throat, sometimes, especially the grandparents, will panic because they remember the days when scarlet fever could be a death sentence, but it just means that there's a rash with your strep now. Next slide. So one of the easiest diagnoses to make, right? Hand, foot, mouth. You have vesicular, very good. You have vesicular, pustular lesions, palms and the soles around the mouth, inside the mouth, in particular, very posterior. The posterior pharynx will have ulcerations or lesions. And I mainly include this because this is more of a younger disease, right? So children under the age of 5 typically will have this more often than other kids. So of course, adults can get this as well. But I include this because as long as they are fever-free for 24 hours and they are not developing new lesions, and most of the lesions are not as wet anymore, they're drying out, these children can return to school. Next slide. So, yeah, thank you. You gave it away, Jocelyn. So, this student comes to your office because a teacher is worried that it's whatever it is contagious. The child complains that it hurts a little bit. and you notice some eroded skin with some honey crusting over the skin. You look inside the mouth, there's not really anything inside the mouth, it's just this rash here. And then you remember that this same child came to you with a similar rash, but underneath the nostril a few months ago that went away on its own. But now they're back with this that seems to be bothering them more. Anybody want to take a guess, especially since you saw the next? Thank you. Yes, that is correct. It is. Next slide. Good job. It's impetigo. Impetigo is is an infection, and it's typically caused by the staph and the strep that usually just live on our skin. We're colonized with it, and it doesn't usually bother us, except in some kids who pick their nose or they pick their lips, and so it creates damage in the skin barrier, and so that usually benign staph or strep gets in under the skin and causes an infection. Yeah, this does require oral antibiotics. Topical antibiotics don't usually cut it, and so they do need to see someone in 12 to 24 hours because it is contagious. Usually, you can give it to other kiddos, but usually you give it to yourself. Like if you have impetigo on your face and you touch it, and you have some other areas on your body that there's skin breakdown, like a bug bite, then oftentimes you'll see that same sort of process going on there as well. Next slide. So next patient case, same scenario in terms of a teacher sending them to you because they're worried that whatever this is contagious. So this is a multilobular vesicle with some whitish fluid, a little bit thin-walled, a little bit of an erythematous base. This student also, when you looked inside the mouth, had one little ulcer on the labial mucosa. And yeah, so they said it's a little bit painful. Next slide. A lot of you knew this one. HSV type 1, herpes simplex virus type 1. When I give this diagnosis, often families get upset because they immediately think of type 2, which is a sexually transmitted infection. So I spend at least a few minutes discussing how that is not a concern here at all. That in fact, HSV type 1 is extremely common. Usually you see anywhere when you look it up, 50 to 80% of the US population has HSV type 1, which means that they don't have a cold sore or fever blister typically, but when they get sick and their immune system is somewhat compromised, this infection does pop up. So that's why they're called fever blisters and cold sores. People think that it's the fever or the cold that causes the sores, but it really is the change in or decrease in your defenses in your immune system that make this pop up. Typically, when you have your first case of this, especially when in the younger children, it's a pretty bad case. They'll have a ton of vesicles and pustules all around the mouth, inside the mouth. They'll have gum swelling. It's quite dramatic. And those kids sometimes end up in the hospital needing IV fluids because they refuse to drink anything. But after that initial infection, usually it's just one or two lesions like this that we treat with antivirals like valacyclovir. Next slide. So as you can tell, these two lesions look pretty similar. These pictures really highlight the differences, but we all know that commonly every day there are lesions that have characteristics of both. And there's no, one of the clues is that with HSV type 1, you can have mucosal membrane involvement. But if you don't have that, then you're not sure which one it is. And sometimes we will scrape the base of a lesion and send it to the lab if we're not sure, especially if it's really bothering the patient and we need to initiate some sort of treatment. So not expecting you guys to necessarily know. Sometimes when it's one of those lesions that it's not really clear, because sometimes we don't know either. Next slide. So I show this because these happen, and the clue, because oftentimes, because I work in the schools with you guys, and you'll send me rashes, and it'll be like some bumps on the skin, and it's really hard to tell what's going on. Is it a bug bite? Is it, is it allergy? But one thing that distinguishes spider bites is the ulceration on the papule itself, because both the black widow, which is the spider above with the classic red hourglass on its abdomen, and the brown recluse, which is the spider below, are venomous, and their venom causes necrosis at the bite site. And so, one clue that it's a spider bite is instead of being multiple bumps, there'll just be one or maybe two large ones. And then you'll have that classic kind of volcano look, the ulceration on the at the bite itself. Next slide. So eczema, we've all seen eczema. 15 to 20% of kids have it, so um, that means you've seen it. Oftentimes we call it the itch that rashes because the rash doesn't start first. It's actually the itch. So a child will have an itchy spot and they'll scratch, 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 and then they'll develop a rash there. Even though it's very common and is mostly considered benign, eczema actually can be quite impairing in terms of sleep, in terms of work and studying. So it really does behoove us to recognize when somebody's struggling with eczema and the itching, and treat them appropriately so it doesn't affect their day-to-day lives. There are two components to eczema always. One is dryness and one is atopy or allergy. So um, the dryness part, as long as you moisturize, usually you can keep it at bay. It is true that living here in Idaho doesn't help because we have a very dry climate. People are always astounded when they go to Hawaii for a week, their child's eczema will completely disappear. And then, of course, it comes back when they come back. So, I tell families like, if you can try to keep up that level of hydration with your moisturizer, and you can get rid of eczema that way. You do have to keep in mind that if there is an allergic component to their eczema, you're going to need to address that and avoid the allergen, or the eczema won't go away. The peak prevalence of eczema is actually in younger kids at age 2. And some people call it eczema because a lot of kiddos who have egg allergy will also have eczema. So if you have especially a younger kid and they're really struggling and you're doing the usual hydration and steroids, it's not working, we will send them for allergy testing. Next slide. So I just show this as an example of a well-circumscribed rash. So eczema likes to go in the inside of the elbows, the flexural surfaces of the elbows, and psoriasis likes to be on the extensor surface of elbows and other joints like knees. But you probably won't see a lot of this because, as you can see, the incidence is pretty low. But it's a pretty easy diagnosis to make because of its kind of singular appearance. This is a well circumscribed rash, or well-defined rash. So you could take a pen and put exactly where the rash begins and ends all the way around these lesions. Whereas with eczema in the pictures before, you could see that they weren't as well defined. So that's one of the ways sometimes if you don't have a classic presentation of either eczema or psoriasis, this is one of the ways that we try to make that diagnosis. Next slide. So you all seen this too, lip lickers dermatitis. The problem here is number one, the saliva has digestive enzymes and basic pH, so it causes irritation and breakdown of the skin. So two, because there's irritation, the child will lick more because the licking will just temporarily relieve that irritation. So this is often associated with eczema. but not always. It can be associated with anxiety, but not always. And the treatment's always the same. You just have to stop them from licking their lips. Sounds easy, right? But anybody who's worked with children and behavior know it's not, behavioral modification isn't that easy. I don't love gum, but sometimes if that will keep their mouth busy, that can sometimes break the cycle. You can also have the child carry around a special lip balm as long as there's no fragrance or dye in it. And when they feel the urge to lick their lips, they can use that instead. But yeah, once you do that, this should go away. Next slide. Okay, next case. So think about what this might be. This is a second grader with an extremely itchy rash, which is actually why they were sent to your office because their itching is driving the kids around them and the teacher crazy. They are 1 to 3 millimeter papular lesions. Some are pink, some are flesh colored, and they're in a more intertriginous distribution. So that means between the digits, so between the fingers or between the toes. Next slide. So yes, somebody got this. It is scabies, and I've worked a lot in Central America, and I've probably gotten scabies 3 or 4 times. It's no fun. And they're not kidding when they say it's itchy. I mean, I'll be asleep and I'll wake up because it's so itchy. It's kind of gross. Anyway, thankfully, the cure is easy. So with permethrin cream, which is a prescription, you have to put it on neck all the way down to toes, every single surface of your skin overnight, and then you repeat that in 2 weeks, and typically it will go away. You might have to warn the family that with treatment, it will temporarily get even itchier because those individual little scabies, when they die, they poop, and that makes it a little bit itchier, which is kind of gross to think about, but actually pretty easy to treat. I don't have a lice slide because as school nurses, you probably know more and have seen more lice than I have. But the one thing I do want to say about lice is that, it isn't, people always think the most important thing is to get some fancy, expensive prescription medication to treat the lice, where actually the best solution is, and again, I think you guys know this because some of you taught this to me, is to just get a good over-the-counter like Nix, which is over-the-counter permethrin, treat, and then just get rid of every single lice, louse, and nit. There are places that businesses that all they do is nitpick every single louse and every single nit out of your child's hair. They do this like intense heat to kill them, and then they spend 1 to 2 hours with your child, depending on how long their hair is, to get those out. It's expensive, but that works even better than prescription medication because it really is about getting rid of all the eggs and all the adults. Next slide. Okay, next case. This is a kindergartner who'd never attended any group setting before, presenting with a maculopapular rash with a cheek distribution and a reticular fine papular rash over the extremities. And otherwise, he's perfectly fine. But the teacher, noticed the rash on the cheeks, and somebody got it. Thank you. Next slide. Oh, everybody got this. So smart. Ooh, I'm not sure what's wrong with my slide. So um, this is fifth disease. It's called that. I don't know why it's still called that because fifth disease is an old nomenclature back from like the 1800s when we did not know anything about pathogens, right? So this was fifth disease. I believe rubella was first disease, rubeola was second disease. There was a third, and I think scarlatina or scarlet fever was like fourth disease, and this was fifth disease. And nobody calls the other things by those other names, but for whatever reason, this one, fifth disease, has persisted as the name of this particular infection. It's caused by parvovirus B19. And I put this in orange, and it's not because of the patient. The patient will be fine. This is a very benign, self-limited disease. The kid's going to get over it, no problem. The issue and the reason why I put this in orange is because parvovirus B19 also causes bone marrow suppression. So that means it can cause a temporary or transient anemia. And that type of anemia is not important to a healthy kindergartner, for instance, but it can be very important to someone who lives with chronic anemia, for instance, sickle cell disease. So I had sickle cell patients where I trained in North Carolina, who, when they would just get this very benign disease, because the classroom had it, and everybody else was fine, but when my sickle cell patient got it, they were already starting with a hemoglobin of 8, and so they would get into crisis. The other reason it's important, because we don't have a lot of sickle cell here in Idaho, but we do have a lot of pregnant women. And what happens is if the fetus gets a parvovirus B19 infection, they will get bone marrow suppression, they will get anemia, which causes significant heart failure in the fetus. And so when you see fifth disease, you need to let the family know to alert anybody that they might be in contact with that is pregnant. So pearly papules with umbilication or dimpling on the top of them. They're in clusters on the trunk, and I know all of you know what this is. Um, Thank you, Deborah. Thank you, Anna. Next slide. This is Molluscum contagiosum. Sometimes they're called seed warts. I'm not fond of that, but whatever. Sometimes that's how people know them. And these are a little bit controversial because if you look online, there's all these miracle cures, witch hazel, etc. But really, the best treatment for molluscum is to just let them be, and they will go away spontaneously. The problem with that is sometimes it takes forever for them to go away. I've seen molluscum last longer than a year. I've seen kids with eczema get bad rashes. People, if they scratch too much, it can get infected all the time. They can be on your face, and that's really embarrassing for a junior high or high school student. And so sometimes treatment is warranted. And over the years, I've treated this by irritating them, freezing them. But the problem is when you treat them, there's a chance they might scar. If you let them go away on their own, they don't scar. So I always like to preface before I treat to let people know that. But as long as they're somewhere where clothing can cover them and they're not disfiguring, I really try to just let these go. One of my kids had this for over a year, but it was only on his back, and so we were able to just do watchful waiting, and they did just kind of all. He had a ton of them, but they all disappeared within a week. Next slide. So ringworm, you'll also see. Um, I don't like the term. Again, it's an old term. There's no worm involved. And it usually starts out as a small papule, like on the left, but it can get untreated. It can get pretty big. And you can see that it's slightly raised, again, with some central clearing, with an active border. And if you biopsy the middle of that lesion on the right hand side, um, uh, then you're not going to see any fungal elements or hyphae. But if you biopsy the active border of it, then yes, you'll most likely come up with some fungal elements or have something grow on a fungal culture. Um, Sometimes this is hard to treat. We start with topicals, but when they get as big as the one on the right, then usually they'll need oral antifungals. Unfortunately, since it's slow growing, it's slow going away. So I tell people if it took 3 weeks to get to that point, it'll probably take 3 weeks of oral antifungals to make it go away. Um, Oftentimes I find that instead of getting it from other children, kids get it from pets. If they have, it's good to ask about a new kitten, or maybe a dog that has an area of balding. So it's zoonotic for sure. Next slide. Pityriasis alba, I included this because this also can cause distress in teenagers. They don't like these white spots, but it's benign. What happens in these areas, these white areas, these hypopigmented areas, is that there's some inflammation. So it is associated often with eczema. And the inflammation is enough to kill the melanocytes, which are the skin cells that create pigment or melanin. And so that white spot stays around for months because it takes a while for those melanocytes to go back into that area and start producing melanin. But until that process happens, it can be upsetting. If that child goes out and tans, then these spots are just going to get even more prominent because you're just going to see a lot more of that dark around that white. So in contrast, they're just going to look worse. So really no treatment for this unless every once in a while, if it looks like a large area, we'll do some over-the-counter steroid, but really just good sunscreen, good moisturizing, and then just time. We'll have these go away. Next slide. Last skin condition, keratosis pilaris, very common in preteens and teens. This is caused by skin buildup in the hair follicle. And so the treatment is all over the counter, anything to help exfoliate. So any of your lotions or washes that can contain acid, like salicylic acid, using a loofah. If they're red, like the picture on the left, you can use a little bit of 1% hydrocortisone cream, and that will all help. But then if you stop the treatment, it'll come back. So it usually lasts months to years. So all you can really do is help it, keep it at bay so it's not as disfiguring and not as irritating. Next slide. All right, last slide. So here are some newer wound care do's and don'ts. You're not supposed to use hydrogen peroxide, and I hope nobody's using rubbing alcohol on an open wound. So we've learned that hydrogen peroxide can kill healthy skin cells and it will delay healing. So it's better to use just a non-dye, non-fragrant soap and water for the minor wounds that I know you're all seeing every day. There is a relatively expensive agent called Active. That's the brand name. It's hypochlorous acid that you can buy, but honestly, mild soap and water is probably the best. And you can keep iodine and betadine for deeper wounds in your offices, but I find that they expire and they're kind of expensive. So yeah, just no more hydrogen peroxide to wounds. When you're dressing a wound, never use anything that has neomycin as an ingredient. And unfortunately, the very popular Neosporin does have that in it. And so I usually steer people clear of that and use bacitracin ointment instead. That's another over-the-counter antibiotic ointment. You just have to look at the ingredients. Neomycin causes a lot of irritation. A lot of people are allergic to it. And so it's not recommended by dermatologists anymore. They don't even offer it in other countries. It's also okay to just use white petroleum or petrolatum ointment. So there's the yellow Vaseline jelly, and then there's the white. The white has just been more purified, so that's my favorite. And some of the brand names are like Aquaphor Intensive ointment or Vaseline. And then when it comes to wound healing, let it keep it moist. Don't air it out or make it dry, especially those deeper wounds. That will delay healing. And that, I think, next slide. So really quickly, think meningococcal disease, even though it's rare, quick and early diagnosis is key. What you're looking for is those petechiae, those non-blanching macules. Think of anaphylaxis for any ill-appearing student with sudden onset difficulty breathing or cough, any facial tongue swelling, and then GI symptoms. And check a blood pressure because that's a good clue that you might be dealing with anaphylaxis. Don't be scared of urticaria unless it's associated with some of those things regarding anaphylaxis. And then finally, don't use hydrogen peroxide on wounds. Just use mild soap and water, and then no no neomycin containing products. And that's all I've got.